Shall I start, sir? Good afternoon, respected judges and all dear delegates. So today I'm going to present a case on bilateral optic atrophy in Crouzon syndrome. So there has been no financial support and sponsorship for this case, and due consent of the patient has been obtained. So as we all know, Crouzon syndrome is an autosomal dominant disorder with complete penetrance and variable expressivity. It is caused by the mutation in the fibroblast growth factor receptor 2, which causes premature closure of the cranial sutures. So the case report that I'm going to present had presented to us at our OPD, a 7-year-old male child from Assam, who complained to us with the chief complaint of inability to follow light or hold objects properly, drowsiness and reduced appetite since 1.5 years. He was brought to us by his parents, and according to them, his vision has been deteriorating ever since, and the features had started developing from birth gradually. So his medical and surgical history were not that contributory. They had visited multiple physicians in their hometown, but in vain. So on the ophthalmic and general examination of the child, we found that his visual acuity had actually deteriorated to finger counting close to face. It was insidious in onset and painless. Proptosis was noted. A protrusion of 24 mm was seen in both eyes. Exotropia of the left eye was noted around 45 degrees. And he had shallow orbits, wide-set eyes. On direct ophthalmoscopy and IDO examination, we found that he had bilateral optic atrophy. He also had beaked nose and depressed nasal bridge, an underdeveloped upper jaw, and open mouth. Maloccluded teeth were seen when he opened his mouth, and skull and facial dysmorphology were also noted. His CNS and CVS examination were, however, within normal limits. On slit lamp examination, the positive findings were he had proptosis. There was the anterior chamber looked proper. Interpupillary distance was 65 millimeters. Corneal diameter was 12 millimeter. The intraocular pressure was normal, and rest every anterior segment finding was almost normal. So this was the patient. The child was brought to us on the first day when we made a clinical diagnosis, and on the second day for follow-up, his mother, as visibly we can see that she also had a left eye exotropia and a Crouzon syndrome. So this was the fundus photograph that was taken, which showed bilateral optic atrophy of the child. An ultrasound B scan was done, which was within normal limits. A CT scan was done, which showed a bilateral exophthalmos. So all the investigations were almost within normal limits. We have also gone for an X-ray skull, PE, and lateral view. So MRI orbit and brain with orthopantomogram has been advised, and patient has not followed up with these reports yet. So a clinical diagnosis of Crouzon syndrome was made and treatment was initiated. So with the treatment plan, we had started on general lubricating agent, antibiotic eye drops, and genteel gel at bedtime, multivitamin supplements, and we have advised follow-up. The parents were counseled of the nature of the child's disease and the reason for poor sightedness. We have also suggested them a neurology opinion to rule out any intracranial hypertension, and dental opinion and plastic surgery opinion. So in the patient, we have seen craniosynostosis from the CT scan that we did. Proptosis was there, left eye strabismus was there, but there was no keratitis. So this was the skull, PA view skull was done, and lateral also, which showed hypoplastic maxilla. The mixed dentition can also be seen with mandibular prognathism, and some few cerebral impressions can be seen. So, and discussion part, we all know that Crouzon syndrome is a genetic defect. It's an autosomal dominant defect, and many studies have been done all around the world, in India, where such craniosynostotic syndromes have been studied. And not only that bilateral optic atrophy, but also such patients present to us with astigmatism, anisometropia, and strabismus. And also, if we go for an MRI or CT scan brain, we see that there can be progressive hydrocephalus or chronic tonsillar herniation and jugular foramen stenosis with venous obstruction. So that has also been found with significant frequency. So these are my references, and thank you.
Thank you. This was a very straightforward diagnosis. How old is this child?
7-year-old, sir.
7 years old. So this should have been detected earlier because it's a very gross Crouzon's. I think nobody should miss this kind of Crouzon's, you know.
Yes, sir.
And optic atrophy is a known thing. It does happen in Crouzon's.
Yes, sir.
And had you done an MRI, you would find displacement of extraocular muscles,
Yes,
especially obliques, circulation and all those things will be
yes,
there. So this should have been looked after earlier with some surgery so that we could have managed to, probably the optic canals are too narrow.
Yes,
That's why that's causing the optic
Yes,
atrophy
sir.
in this case. So it should have been probably managed earlier, whatever surgery
Sir,
is
they
required.
presented to a tertiary healthcare center for the first time. They had been visiting small doctors
That's what I'm saying.
and
This
physicians.
is very gross occlusions. Nobody should miss it. At times,
Yes,
occlusions
sir.
is very subtle, and you may miss occlusions because they are not gross findings. But here, it was something which is very textbook kind of picture, and they have very large exotropia, V pattern, all those things are there, and so I think we should be aware of these craniosynostoses and not miss these conditions.
But why is it there?
Because in Cruzon syndrome, though we generally find bilateral optic atrophy, but if the case had been managed earlier, like the nerve compression could be managed by some plastic surgery for just to correct the craniosynostosis or the facial dysmorphology.
Yeah, that should have been done. That's what I'm saying.
Yes, sir.
Now, once
So,
the optic atrophy has happened,
has already
it's very
happened.
difficult to get back things.
Yes, sir.
Anyway, I think earlier the better. So you should advise the child whatever is appropriate.
So the parents also have been counseled that the child needs a neurology opinion, also a plastic surgery opinion to correct, but the vision cannot be recovered.
Thank you. Anything, Dr.
I
Parikshit,
think
you want to-
it goes more in the hands of pediatricians that they should, refer. Maybe
Yes, sir.
he might not have seen a ophthalmologist. Otherwise, it would have been diagnosed earlier.
Yeah, pediatrician should have not missed it, and we should have also not
Yeah,
missed
true,
it. So it is a joint responsibility, I think.
True.
Thank you so much. sir.
Thank you, sir. Thank you.
So we can start with the next presentation. Information number देंगे। किस पर्ची में से भी कितने? कितना दिया इनको? ये लिखा हुआ है पर्ची पर। Fourth one. Second and third are not there.
Shall I start?
Yes.
Very good afternoon, respected chairperson and dear audience. I am Dr. Ravi Kumar. My topic of presentation is study of the refractive changes and ocular biometric in preterm and term infants. My co-author is Dr. Suchita Paridas. He is additional professor at AIIMS Bhubaneswar. I have no financial interest. So preterm neonates born before 37 weeks are prone to various ocular problems like ROP, refractive error, strabismus, and amblyopia. Worldwide, 15 million neonates are born premature, and full-term healthy newborn is generally born with axial hyperopia, and preterm newborns are noted to have myopia, hyperopia, and astigmatism at birth, depending upon the gestational age and stage of ROP. Previous studies focused on ocular biometry after ocular stability age, that is 3 to 16 years, and information regarding refractive status in infants in whom dynamic ocular changes are ongoing are still limited. So the aim and objective of this study, the primary objective was to compare refractive changes and ocular biometric between preterm and term infants in Indian scenario, and the secondary objective were to compare the refractive outcome in preterm infants with ROP and without ROP, and to study the association of refractive error with the birth weight and gestational age. This is a cohort study incorporating 90 infants, 45 age-corrected preterm and 45 term. Inclusion criteria were preterm and term babies born at AIIMS Bhubaneswar between January 2019 till December 2019, and exclusion criteria were babies with systemic comorbidities like severe sepsis, hypoxic ischemic encephalopathy, or on mechanical ventilation, and ocular comorbidities like congenital cataract or corneal opacities, and syndromic babies were also excluded. In Group A, the age-corrected preterm babies were taken, and in Group B, the age-corrected the term baby were taken. And growth parameters and ocular parameters were recorded. In growth parameter, it were gestational age, birth weight, length, and hair circumference. And in ocular parameter, corneal diameter, cycloplasic retinoscopy, A scan, and fundus examination was done. The first follow-up was done at 3rd month, the second follow-up at 6 months, and the last follow-up was done at 12 months. And growth parameter, refractive error, and ocular biometrics were recorded at the follow-ups. Coming to the results, this is the table showing the baseline demographic distribution of infants, comparing between the preterm and term on the basis of gender, mode of delivery, number of twins or triplets, and socioeconomic status. There was no any significant difference between these two groups on the baseline. These are the two tables showing the refractive status of preterm and term infants at birth and 12 months. Here we can see that the preterm babies are more prone towards having myopia, whereas the term babies were more towards the hyperopia. And on comparing these two, at 12 months, the emmetropization was similar in both of them, and there was no any significant difference between the preterm and term babies. Coming to the secondary outcome, this is the pie chart showing the distribution of the ROP among preterm infants. And among 45 total preterm infants, 5 infants had ROP. The worst staging was zone 2, stage 2, and when independent t-test was conducted, it showed no difference between the ROP and no ROP with the p-value of 0.64 in our study. This is the plots showing the correlation between the mean spherical equivalent to the gestational age and the birth weight. Here we can see that the birth weight is strongly associated with the spherical equivalent more than the gestational age. This is the plot showing the comparison of the mean spherical equivalent and its increment within infancy. Here we can see that the preterm babies are initially deviated towards myopia, and then it went towards emmetropization, whereas the term from initially only they were emmetropizing smoothly. So coming to the discussion, Larson et al. And Saunders et al. Stated that among preterm and mild ROP or without ROP, there is myopic shift initially and delayed emmetropization, which was seen in our study. And Pennefather P. et al. Stated that there is no significant difference between the no ROP and stage 1 and 2 ROP. Varghese R. et al. Also found that the birth weight is more correlated to the final mean spherical equivalent than the gestational age, which is according to our study. Coming to the conclusion, preterm infants have tendency to develop myopia, whereas term infants hyperopia. There is no significant difference in emmetropization among preterm and term infants at the age of 12 months, and among gestational age, birth weight is more associated with the refractive status at 12 months. These are my references. Thank you. Thank you for your patience listening.
Thank you for the interesting presentation. Only thing is that I think we are all born by and large hypermetrop, and slowly we emmetropize and move towards myopia.
Yes, sir.
Of course, somebody an isometrop, those things are different, or congenital high myopia. So other things, I think in preterm you should have seen those who have gone to nursery who have got oxygen, and those who have not got oxygen, ROP vis-a-vis.
They were more prone to have
ROP ones are going to have a lot of myopia. I mean, that's a known thing.
Yes.
So all those, and anyway debate is going on myopia, how, I mean, rising incidence of myopia it's like an epidemic which is happening. So a lot of issues are there.
Emmetropization continues now till 6 years, so you have to continue. By 12 months, there's still so many changes which occur till 2 years of age in normal individuals.
Yes, ma'am.
So just at 12 months, you cannot say emmetropization is completed. So you can continue this study till 5 to 6 years and see what it is. That's all. It starts at that age.
1 year is a very
Short period to say, okay, emmetropization has occurred and you're comparing.
I just wanted to ask one question. Those 5 babies who underwent ROP treatment, did you include it in the study or you excluded out of the study? Because once you have an ROP laser, that itself is an independent risk factor for myopization. So that will skew your result more in terms of myopia in one group.
Sir, the worst staging was zone 2, stage 2 only, and they didn't require any.
Okay, those were without therapy. So you included them.
Yes, sir.
And the second term, as ma'am mentioned you, at 12 months we don't expect emmetropization. You can say the refractive change itself, but emmetropization will need a lot of years to get.
Yes, sir.
And third thing, important thing is the previous studies have done, and it has shown the most common refractive error is this astigmatism. Rather than myopia, hypermetropia, it is the astigmatism which is more common in preterm babies. Okay. So did you look for the cylinders or only spheres?
Sir, I looked for the cylinders also, but it was varying. In preterm, they were most of them were like myopic, then hyperopic.
The reason being the cornea itself changes,
yes, sir,
from
yes,
birth to 2 years, it changes its curvature.
The thickness and everything.
See, for, yeah. So how did you do the refraction? You did some UA or something like that? Or
The refraction, ma'am, I did the refraction by own with retinoscopy, ma'am, only.
with retinoscopy only?
Sir, cycloplegic, but for cycloplegic we use only that midriasis, sir, midriatic drops, tropicamide diluted one. No cycloplegic, just midriasis, sir. Uh,
Thank you, I think we call the next one.
Thank you, sir.
Nice presentation. Next speaker, Dr. Parikshit.
Yeah, the next speaker is Dr. Tejaswi K.
Good afternoon, everyone. I'm here to present a case, a paper titled Essay of Torch Profile in Congenital Cataract Patients aged 0 to 4 years at a tertiary eye hospital. TORCH is an acronym for toxoplasmosis, rubella, cytomegalovirus, herpes simplex virus 1 and 2, and others HIV 1, 2, treponema pallidum, and varicella zoster. These are recognized as potential causative agents of congenital cataract and can be acquired in utero during delivery or community acquired, and can present clinically with systemic and ocular manifestations during the neonatal period or later in life. Hence, congenital cataract should be early identification and management is the need of the hour. The other etiologies of congenital cataract include idiopathic, genetic, metabolic, trauma, systemic causes, drug reactions, and radiation. The present study is a cross-sectional study done for a duration of 12 months, January 2021 to December 2021, at a tertiary eye hospital in southern India on all clinically diagnosed congenital cataract patients aged 0 to 4 years and excluding the traumatic cataracts. Clinical history, ophthalmic evaluation, TORCH serology for IgG and IgM antibodies using alpha, enzyme-linked fluorescent antibody assay, which is the higher version of ELISA for TOX, CMV, and rubella, and ELISA for HSV 1 and 2 were done. Statistical analysis was done using SPSS V21 software, and p-value less than 0.05 was considered to be statistically significant. IgG positive, M positive, or IgG plus M positive cases were considered to be seropositives, and case definition of congenital cataract was taken as lens opacification at birth identified within 0 and 4 years of age. Out of the 49 congenital cataract cases, 43 were seropositives, constituting 87.75%, out of which 36 cases were bilateral. The mean age of presentation was 15.57 months. A male preponderance has been noted. 3 out of 43 mothers had fever during gestation, which was statistically not significant, and other ocular associations of microphthalmos, nystagmus, strabismus, chorioretinitis were also noted. Pediatrician referral for systemic evaluation was also done. Out of the 43 seropositives, IgG positivity constituted 37 out of 43 cases, while the rest, 6, constituted IgG and M positivity. Anti-CMV IgG positivity rate was higher among the IgG positives, while anti-HSV 1 and 2 IgM positivity rates were higher among the IgM positives. On looking at the seropositivity of the individual agents, CMV alone constituted 11 out of 43 cases, while a combination of rubella and CMV constituted 12 out of 43 cases. The following slide depicts the graphical representation of the same. The results of the study correlate with that of Mahalakshmi et al., that is, association of congenital cataract with TOX, rubella, CMV, and HSV 1 and 2. The following slide depicts the various observations of various studies, in which study design, sample size, duration, age group are different. Hence, an absolute comparison cannot be made. while a significant correlation of higher anti-CMV IgG positivity rate has been noted. In the present study, anti-HSV IgM positivity rate is higher, while compared to the other studies in which anti-rubella IgM is higher. The possibility of false positive reactions, cross-reactions need to be borne in mind while interpretation. A larger sample size and longer duration of study needs to be done to extrapolate the results to a larger population. IgG levels are significantly higher, hence further testing of maternal serology needs to be done to collaborate its transmission to the newborns. Prevention is always better than cure. There is an increased need of vaccines and preventive measures to prevent TORCH infections to the mother and newborns. Evaluation of TORCH profile enables the clinician to be vigilant for the other associated syndromic presentations, both systemic and ocular, and hence timely referral. A significant lag between the observation by the parent and presentation to the clinician has been noted in the present study. This highlights the major role of awareness and accessibility of these patients. Hence, the knowledge, attitude, and practices among the parents and healthcare workers needs to be enhanced. The following are my references. Thank you.
Did you, all these children you investigated for TORCH, and
Yes, sir.
how many you think they were because of TORCH and how many you think were not because of?
So we had, out of the 49 cases of congenital cataract, 43 were TORCH positives. The positive predictive value of this test is higher, 92%. Hence, most of them are TORCH positive cases, sir.
So you
But
mean
there
only
were,
6 children, only 6 were non-TORCH, and vast majority were TORCH positive.
so there is a caution in interpretation of this TORCH serology. This could be used as a screening test, but it's not a gold standard diagnostic test.
That is what I'm saying.
Yes, sir. This is,
Very high incidence.
yes, sir. This is very valuable for screening. But even in the screening, we can find out that the IgG positivity rate is higher, which indicates a chronic infection or reinfection or recurrences, and maternal viremia also. Sir.
Children from 0 to 4 years.
Yes, sir. 0 to 4 years.
Could also be developmental cataract, possible somebody having galactosemia or whatever.
Yes, sir.
Those issues are also there. Something. I mean, there's a lot of metabolic reasons, lot of
Yes, sir.
So I think that's also a bit presumptive that everybody at the age of 4 years was taken, presumed to have been congenital cataract. I think that's also a bit of
The main point that has to be noted here is the identification, observation by the parents and presentation to the clinician is different. And as well as the morphology of cataract, that is the embryonic nucleus as well as the fetal nucleus involvement, in these cases has to be considered while interpretation, sir. So that is why up to an age group of 4 years was considered. And in this present study, we have noted that 29 cases presented the patients observed at the time of birth. But then later, the presentation was, they differed. They presented up to
COVID
1
was
year.
there. COVID, you did it in the pandemic
Yes, ma'am.
time.
There was a 3 month of COVID duration. Hence, we could have got a larger sample while interpretation. And hence, I have presented it as a limitation of the study, ma'am. That could be a possibility due to the immunocompromised state in these individuals, sir.
anything you want to say?
No, sir.
Thank you, sir.
Thank you, doctor. Dr. Rupa Gupta. Dr. Rupa Gupta. Dr. Neha Shilpi.
What's your name? Which number? Last but one.
Good afternoon, judges and delegates. So my topic is comparison of topical interferon alpha 2b versus tacrolimus in refractory vernal keratoconjunctivitis. I have no financial disclosures to make. VKC, as we know, is a bilateral recurrent chronic ocular inflammation caused due to severe allergy. Males, usually in their first and early second decade, and those residing in warm climate are affected.
The disease is usually self-limiting, but it can be sight-threatening if not appropriately managed. For mild disease, antihistaminics and mast cell stabilizers are usually prescribed, but for moderate to severe disease, steroids form the mainstay, but they can't be given long term because of the side effects of cataract and glaucoma. Therefore, sparing agents came into play like cyclosporin and tacrolimus, but again they had the side effect of stinging and burning sensation. So our research question was, do we have an alternate option with equal efficacy or better efficacy than tacrolimus and lesser side effects? So the purpose of this study was to compare topical interferon alpha 2b with tacrolimus in refractory vernal keratoconjunctivitis. This was a prospective randomized interventional study conducted from March to July 2022 at Rio RIMS Ranchi. Ethical clearance was obtained from the Institute Ethics Committee. We included patients with VKC aged 5 to 15 years who were not responding to conventional treatment. We excluded patients with any other ocular disease like glaucoma or uveitis, any ocular infection, keratitis, allergy to any drug, or those on any immunosuppressive therapy, and contact lens wearers. The VKC scoring system was adapted from previous studies. In this, we calculated total subjective symptom score and total objective sign scoring. Symptoms included itching, photophobia, foreign body sensation, and tearing. Signs included conjunctival hyperemia, upper tarsal papilla, limbal activity, keratitis, and discharge. Scoring was done from 0 to 3, where 3 indicated the severity of disease. Patients were randomly distributed in 2 groups. In group A, patients were prescribed eye ointment tacrolimus 0.03% 3 times a day, and in group B, patients were prescribed eye drop interferon alpha 2b 1 million international unit per milliliter 3 times a day. Patients were followed up at 1 month, 3 months, and 6 months. Coming to results, both groups were similar in terms of age and gender distribution. The total subjective symptom score and total objective sign scoring in both the groups showed a significant improvement when compared to baseline at all the follow-up visits, that is at 1 month, 3 months, and 6 months. The paired t-test was done to show this. So the intra-group p-value was significant in both the groups. When both the groups were compared among themselves, that is when inter-group comparison was made using unpaired t-test, the values were insignificant at baseline and at 1 month, but at 3 months and 6 months follow-up visits, the interferon group was better compared to the tacrolimus group. 8 patients in tacrolimus group complained of burning sensation, while none in interferon group had such complaint. So tacrolimus, as we know, inhibits T cell activation and IgE dependent histamine release via cyclophilin receptors. Interferon alpha 2b also has the anti-inflammatory properties by same mechanism. It stabilizes mast cells and inhibits arachidonic acid metabolism. This was a study conducted by Zanzani et al. Which compared interferon with tacrolimus, and they also found that both are safe and effective, while interferon resulted in greater improvement and had fewer side effects. But this study had a follow-up period of only 2 months. Plus tacrolimus concentration they used was 0.005%. This was another study conducted by Gupta et al. Where they concluded that both are effective and safe. However, the design of the study was retrospective. So to conclude, both interferon alpha 2b and tacrolimus are safe and effective in steroid resistant VKC. However, we found that interferon alpha 2b results in greater improvement and is better tolerated. The limitations, however, of our study are short duration of follow-up and small sample size. Thank you.
Which part of the country you had this report? Which part of the country is it?
Sir, Ranchi, Jharkhand.
Ranchi. So there's a lot of sun there, so a lot of spring catarrh.
Yes,
Only
sir.
thing is when you declare them refractory.
Sir, if the patients were not responding to 4 weeks of steroid therapy, even after 4 weeks.
Not responding means what? We have to have some criteria. What we
Yes,
call
sir.
as non-responder.
Yes, sir. Yes, sir. So based on the total objective scoring and the total subjective scoring, the patients were scored, and if the score was like more than 20, so we considered so we labeled them as non-refractory. Even after 4 weeks of therapy, if the scoring was more than 20, then we labeled them.
After 4 weeks of therapy.
Yes, sir. Yes, sir.
Short time, I think.
4 weeks of steroid therapy. Yes, sir. Yes, sir.
And which is more expensive, which is out of these 2 drugs which you have compared, interferon and tacrolimus, which is costlier? Cost is the same.
Cost, I'm not very sure, sir. I think.
That is the cost.
Yes, sir. Interferon, yes, sir. Yes, sir.
Any side effects seen with interferon?
Not in our study, we didn't see, sir.
And with tacrolimus also only the stinging and burning
Yes, sir.
purpose?
Yes, sir. Just that. Interferon alpha 2B, the injection interferon is available. It is 3 million international unit per in 0.5 ml. So we mixed it with artificial tears 2.5 ml and we got the concentration of 1 million international unit per ml. So we had to prepare that.
It's already in use for
No, we called the patients every 3 weeks, and then we used to give them.
Actually, sphincter is a very variable and very difficult
Yes,
condition. I
agree,
think,
sir.
and
Yes,
there's a
sir.
lot of difference from patient to patient. And
Agree,
age
sir.
group.
Yes, among the immune response of the patient also decides
I
the
think,
response.
So we need a larger and long-term
Of
study
course.
to probably
Yes, sir.
figure out something.
Yes.
Like the tacrolimus is available for getting interferon prepared, the patient has to report every 3 weeks.
Yes, sir.
So
Yes,
the
sir.
The compliance factor and the patient follow-up also, that also becomes
That
a
also
guiding
becomes
factor
important. Yes,
in
sir.
this comparison.
Yes.
How many patients were lost to studies because of not reporting?
Sir, in our study, we kept a close follow-up, so we didn't find any loss to follow-up. So the sample size was smaller. We strictly adhered to that. Means all the patients were called strictly for follow-up. We used to call them and all.
Probably they
So
were
they
quite
were-
troubled, so anyway they came for follow-up. Thank you.
So I just wanted to one question.
Yes.
When you put the patients on your study drugs, were they on steroid or off steroid?
They were off steroid.
They were off steroid
Yes,
and
sir,
off anti-stomach like olopatadine
Yes.
and everything.
Yes, sir. So 4-week gap was kept and they were off steroid, off antihistaminics. Only lubricants were prescribed for 4 weeks. And then they were started on this therapy. A 4-week gap was there.
So there was a gap of 4 week of steroid and then it, I mean, do you think that the person who is not responding to steroid will respond with this thing? Because all those drugs are basically for supplemental therapy, that is steroid sparing agent. Once
sir.
it is already been stabilized on steroid.
Yes, sir.
So, but what we practice is that we give steroid and then even after steroid therapy the patient is not getting relief, then we add it on and then
Add
take
it.
off the steroid.
Yes,
This is
sir.
the preferred practice pattern.
Yes, sir.
But
Sir,
as per
actually-
your study, we can start directly with the.
No, sir. What we actually wanted to see was whether the effect was only because of this drug or if any added effect of steroid is there. So we didn't want to see the added effect with steroid. We wanted to see the effect with only this drug.
So there is only
So therefore-
last question. Would you
Yes.
prescribe steroid or a tacrolimus as a first instance if the patient reports?
If the patient comes first, we'll of course give steroid for exacerbation. But then we wanted to see other steroid sparing agents. which
Your
we can
basic
prescribe
purpose
for
was to
long term.
compare between two drugs.
Yes, sir. Yes, sir.
She wanted to spare steroids, I think.
Yes, sir. Yes, sir.
Thank you.
Thank you.
Your last one?
Sorry.
Komal Singh, she's Komal.
Nishi Prasad is not there?
Yeah, she's also there. That means you are one of the
Prasad.
absentees.
No, she is here, next page,
No, Komal
Acha,
Singh
आगे
and
भी है।
Mohit Dogra. Komal Singh. Mohit Dogra. Not there.
So यहाँ भी दो हैं. I didn't know. We have to finish in time, I think. Then let's discuss. How many are
They
there?
we are still
That's all, we are
going on time, sir.
ahead of
Okay, okay. Perfect.
Going on time.
We'll have less speakers, I think.
Please.
Fetal hemoglobin and development of retinopathy of prematurity in preterm babies. So ROP is a multifactorial disease primarily affecting the premature retina of infants. Apart from birth weight, gestational age and oxygen, there are multiple biomarkers that can affect the development and course of ROP. One of such biomarker is fetal hemoglobin, which are predominantly present in neonates at birth. HbF is the main oxygen carrier protein in the human fetus, which is involved in transporting oxygen from mother to fetus. The aim of this study was to find an association between fetal hemoglobin concentration and development of ROP in preterm infants. So this was a hospital-based prospective observational study done for a period of 1 year in Department of Ophthalmology, Gandhi Medical College, Bhopal. All preterm infants with less than 37 weeks of gestational weeks and less than 2.5 kg birth weight attending the ROP clinic was included in the study, and data was compiled and statistically analyzed.
So a total of 410 preterm babies was included. Among them, 110 developed ROP and 300 did not develop ROP. And those who developed ROP was further studied for regression or progression of the disease, and fetal hemoglobin was compared between all the groups. So this is the basic demographic characteristic with respect to ROP. So although there was male preponderance, but not statistically significant, and those infants who developed ROP had a lesser gestational age and birth weight and statistically significant. This is the mean fetal hemoglobin graph with respect to gestational age, in which we can clearly see that those infants who developed ROP had less fetal hemoglobin levels compared to those who did not develop ROP in all the gestational age groups. Similar findings were observed with birth weight. Those infants who developed ROP had a lesser fetal hemoglobin levels in all the range of birth weight till 2 kg. This is the distribution of fetal hemoglobin with respect to ROP. So those infants who developed ROP had a lesser fetal hemoglobin levels compared to those who did not develop ROP. Similar findings can be seen here in the graph with mean fetal hemoglobin levels with ROP. Those infants who developed ROP, it was found that fetal hemoglobin level was inversely proportional to the stage of the disease. The infants with higher fetal hemoglobin had less severe disease. And those infants who progressed to an advanced disease had lower fetal hemoglobin levels, which was statistically significant. So this is the ROC curve, predictive ability area under of the graph showing 0.974 and the predictive probability. So we can see a clear line at the fetal hemoglobin level of 56%. Those who developed ROP had a lower fetal hemoglobin, less than 56%, and those who developed ROP had a higher fetal hemoglobin level. So the mean fetal hemoglobin was significantly lower in the ROP group than in non-ROP group. Higher the fetal hemoglobin value, lesser was its association with ROP. The concentration of fetal hemoglobin was also significantly associated with severity of the disease. Higher the concentration of fetal hemoglobin, lower was the staging of the disease. More concentration of fetal hemoglobin was found in the ROP infants who regressed, and less concentration in those who progressed to an advanced disease. And all the cases who progressed to an advanced stage has fetal hemoglobin of less than 60%, so it can be concluded that the probability of developing ROP and its progression is less with fetal hemoglobin of more than 60%. So conclusion, low fraction of fetal hemoglobin in the initial postnatal weeks was independently associated with the development as well as progression of ROP in preterm infants. Conversely, maintaining a higher levels of fetal hemoglobin may be protective for developing ROP. And fetal hemoglobin can also be considered a predictor for progression of ROP. This was a hospital-based prospective observational study. Larger studies are required to investigate these associations further. My references. Thank you.
Thank you. Did you compare this with hemoglobin levels? Were these anemic children? Between fetal hemoglobin and anemia? Because if children are anemic, they are more likely to get into ROP.
Yes, sir. But we had looked in all preterm infants, sir, irrespective of anemic conditions.
But you should have, I think, taken hemoglobin levels also.
Hemoglobin,
because some children who were anemic, less than 8 hemoglobin, they would be far more likely to get into ROP as compared to children with more than 8 or more than 11.
Okay, so we had included only fetal hemoglobin. Okay. I have included less than 2.5, but then in our less than 2.5 kg, ma'am. Less than 2.5. Till 2.5.
And you say that fetal hemoglobin is protective. So how do you increase its level?
Fetal hemoglobin levels.
I think it's an indirect.
What happens to fetal hemoglobin? I think I don't know. I remember everything now offhand.
Fetal hemoglobin
Slowly dissipates.
It slowly replaced by adult hemoglobin, and all of them are replaced by the age of 1 to 2 years, sir.
1 to 2 years.
Yes.
So I think in that age group you were studying, you should have also looked at the anemia, I mean the hemoglobin, the adult
Hemoglobin with
component, because if they were anyway anemic, they are more prone for ROP.
developing.
Anemia is the confounding factor, which has not been thought of.
known factor. Yeah. So less than 8 it really rises.
Even the response of laser depends on the anemic status of the child.
Yes.
Those children who don't respond with the 1 or 2 this thing of laser, they are given blood transfusion.
Thank you. Thank you, Dr. Sir.
Thank you.
Dr. Komal Singh. She was Nishi Prasad. Four are missing.
put a timer. उन्हीं का timer चल रहा है.
Good afternoon, respected judges and all the delegates. I'm Dr. Komal Singh, PG resident from AIOCMTC1, presenting a paper on the topic ocular effects of refractive error in children or pediatric population. I have nil financial interest. So an easily detectable and correctable condition like refractive error still remains a significant cause of avoidable visual disability in our world. In India, it is considered as the most common cause of blindness after cataract. Accommodation and convergence system have a great role in maintaining binocular single vision through their components such as accommodative response, facility, amplitude of accommodation, near point of convergence, negative and positive relative accommodation, and negative and positive fusional vergence. So treating myopia in infants is usually unnecessary, but children should be corrected with spectacles or contact lenses. There may also be asthenopic symptoms in emmetropic eyes, especially in this COVID era, where a whole of the education system has been shifted from classroom to digital screens, which has led to development of disorders like convergence insufficiency and poor accommodation, which is treated with orthopic exercises. So the aim of the study is to study the effects of refractive errors on asthenopia, accommodation, and convergence. Subjects for this study were selected from the patient attending the pediatric ophthalmology clinic in tertiary care center, eye care center, as per the inclusion and exclusion criteria. And it is a hospital-based cross-sectional study which included the patients of 2 to 18 years of age group. Total sample size was 270, which is further divided into 3 groups. Group 1 included 90 subjects with no refractive errors. Group 2 included consecutive 90 cases of myopia plus minus astigmatism. And Group 3 had consecutive 90 cases of hypermetropia with or without astigmatism. So population of age group 2 to 18 years, patients with uncorrected or no refractive error were included in the study, and subjects who were uncooperative for refractive error or detailed orthoptics evaluation were excluded from the study. So the results, I found that the almost 98% of the subjects in emmetropia group were presented to the OPD with the asthenopic symptoms, while around 70% of the myopes exhibited symptoms of asthenopia. And around 40 to 45% of subjects in myopia group had asthenopic symptoms. In accommodation, in mean binocular NPA was worst in hyperopes, which was measured to be around 17 centimeters, which is followed by emmetropes, which is around 11 centimeters, and in myopes it was around 10 centimeters. Facility was almost comparable on the group, almost comparable on the 3 groups. PRA was also comparable. It was slightly on a higher side in myopes, and NRA was slightly on a higher side in hypermetropes. So disabling asthenopic symptoms were associated with uncorrected refractive errors, defect in ocular motility, and accommodative or a convergence insufficiency. So the presence of asthenopia was significantly more in emmetropia group as compared to refractive error groups, and this can be due to higher visual demands in emmetropic patients as compared to emmetropic ones, for which they need to visit the hospital. Asthenopia in emmetropes is due to accommodation and convergence insufficiency. A study concluded that the lower degrees of myopia, hypermetropia, and astigmatism are the major causative factors for asthenopia. Asthenopia in myopia is due to the patient has to rely on increased positive fusional vergence for single vision to near point in order to replace the absent reflex positive accommodative convergence. While asthenopia in hyperopia is due to the excessive accommodative response, which leads to increased ciliary muscle tone to attain the single vision to near object. The NPA in emmetropes is poor, which explain why these patients present to OPD with asthenopic symptoms. Such patients are unable to accommodate without the help of convergence. And higher value of NPA in hyperopia is because patient overuses accommodation. Facility is comparatively reduced in myopia and hypermetropia because of poor accommodative response in myopia and poor divergence insufficiency in hyperopia. Higher value of NRA in hyperopia is attributed to requirement of higher convex lenses to relax the excessive accommodation hyperopia. MEM retinoscopy in group 2 suggests the lead of accommodation, which justifies the excessive accommodative response in myopes, while MEM in group 3 points towards the lag of accommodation, which further explains the loss or the reduction of accommodative response in hyperopes. Mean convergence was significantly more in myopes and hyperopes as compared to the no refractive error groups. So I conclude that the presence of asanopia was significantly more in no refractive error group as compared to refractive error groups. The limitations were, as it was a tertiary eye care center, so our population may not represent the entire Indian population, and it was a cross-sectional study. And it was done with the patient wearing the full refractive correction in the trial frame, so the precision in the values like NPA, NPC may have been compromised. These are my references. Thank you.
Thank you. What is the age group you used?
From 2 to 18 years of age group.
How can you measure in 2-year child all the tests?
Ma'am, the age group with that we had in my study was mostly above 5, but we had included this age group of 2 to 18 years.
Like how can you do it?
Yes,
cannot
yes.
think.
But other thing is that you have not told us what you took as emetropia, what you took as hypermetropia, and what you took as myopia. You did not tell us.
Like
What was emetropia according to you?
emetropia,
What?
the number of patients.
No, what you called emetropia.
Okay.
What you defined as emetropia. Because
The
nobody
patient-
is born with zero error.
Yes, sir.
Nobody is born with, nature is not perfect.
Yes,
There is
sir.
no scale.
Yes, sir.
It cannot make anything as perfect as zero. There will be some error.
Yes, sir.
So do we call, then what is emetropia? That is the point.
So emetropia,
Clinical emetropia, let us say that.
so emetropia is a condition where parallel rays of light from infinity lies at the retina.
You are talking theoretically.
So
I
if
think
there is
clinically we have
on retinal we had.
nature cannot produce that perfect optical system.
Yes, sir.
Nature has no will.
Yes, sir.
And there are a lot of variables, emetropization, change of corneal curvature, change of
Yes,
lens curvature, a lot of things have to happen in the eye. When the child is born and he is cerebrotic, whatever.
Yeah.
So a lot of things are happening and it is trying to catch up and cope up with a lot of difficulties.
Yes, sir.
So we have to know what is clinical emetropia, which you are not telling us.
Right.
So you please look at this, that when what we call as emetropia, what we call as hypermetropia or myopia, high hypermetropia, high myopia, high hypermetropia, because those things, and depending upon the age group, things will change. What you prescribe in a particular age group may not apply to other age groups. Good presentation. Anything, Dr.
No,
Did you want to say something?
Ma'am, whenever you present next time,
Yes, sir.
you keep the written material slightly less.
Yes, sir.
Press biopic people like us have difficulty reading it.
Yes.
We will
So
have a
just as
phenopia then.
yes,
Okay.
it's
Yes.
We don't have your kind of now. So you'll find out about those things.
Yes, sir. Yes.
See, whatever you are presenting, you should have clarity about what you are talking.
Yes, sir.
In your case, you don't have clarity.
She
You
has
have lot of
collected the
material
patients
put
who came
together, very good effort.
and then she
Appreciable. But you should have clarity what you are saying. But any work, any scientific work, I think that should be not general. Otherwise, it becomes a racket.
and then
Yes, sir.
difficulty in
Thank you, sir.
I think
can we ask
so
if
with that
somebody has
we
come from
come to end of this session, and I think we have finished on time.
can we ask if somebody has come, I mean the ones
Anybody
Yogesh Jai Bhai,
Anybody who wants to present?
Santosh Agrawal, Rupa Gupta, and Mohit Dogra.
And certificates you will get online. They are not to be given here. Certificates of participation you don't get them here. They are online, I think. Online. Thank you so much, all of you.
Thank you.
Thank you, and thank you for the audience for
Yeah.
staying put. Can we have a
Nice
picture?
presentation.
yeah sure
No, with the man.
I'll just
हाँ इनको ही बुला लो सबको बुला लो स्पीकर को भी बुला लो पहले हमारे लो फिर बच्चों का भी दे लो